and Women's Hospital Division of Social Medicine and Health Inequalities. She serves on several boards, the Commonwealth Fund, the Cincinnati Children's Hospital Medical Center, and the Theta Care Center for Healthcare Value. Prior to joining the Institute for Healthcare Improvement, she served as CEO of the Massachusetts Respiratory Hospital and as Senior Vice President for the Duran Institute. Maureen is a frequent speaker at major healthcare conferences on quality improvement and a tireless advocate not only for change, but most importantly for patients. It is my very great pleasure to welcome Maureen Bisognano.
Thank you. Thank you so much, and it's such a delight to be with you all here this morning and to really be thinking with you about different ways that we can approach some of the amazing problems that Dr. Etienne outlined for us this morning. So I will be talking about All Teach, All Learn. That's the way that we work at the Institute for Healthcare Improvement, the organization that I lead. And I think today we're here together, as Dr. Etienne said, to begin to bring all of the knowledge from around the world to bear on the problems that we've got, to create a new sense of commitment about some of the things that we need to do. So recently I was in Africa, and I took this picture because it represented, I think, a little bit of the sense that we'll all have here today. On the wall in the airport, it said, if you want to go fast, go alone, but if you want to go far, go together. And that's what I think we're joining together today to say we have a long way to go. And so the best way for us to go is together. We've got so many challenges right now with the aging of our population, with some of the increase in burden of chronic diseases. And I think for me at the Institute for Healthcare Improvement, it means that we need to move toward what we call the triple aim. It means that together we need to not only work on improving health care, but as Dr. Etienne said this morning, we also need to work upstream on health, and we do need to address this question of cost. So when you think about it, working harder, working longer, working more is not going to be the answer. We need a total transformation in the way that we provide health care and in the way that we produce health. So the speed of change is breathtaking. We've already heard that here today. When you think about the aging of the workforce as its own problem, we need more carers at a time when carers are aging and actually beginning to retire. We're looking at the speed of research and development. We're looking at technological advances. The speed of change is breathtaking across the world, and in healthcare, it's even faster. So as I travel around the world, and it's so wonderful to see so many of my friends from different parts of the world here, what I'm seeing is that healthcare leaders, regrettably, I think, are falling into two categories. I'm finding that some of them are so stressed by the challenges I've just outlined that they're focusing down. They're actually saying, we're going to do less. We're going to close the doors. We're going to define our work in a different way. And other leaders, like the ones here in this room, are saying the challenges are so big that I've got to make new connections. And that's what I think we should be thinking about. As Jim Collins would say, today is the time to embrace the genius of the and, to really start to think that it's not just healthcare, it's health and healthcare. It's not just providing care to patients, it's providing care with patients. It's thinking in so many different ways about new partnerships. So what I'm asking you to do today is to think about embracing the genius of the and instead of the tyranny of the or. And what I'm hearing from those first group of people who are so focused in is they're saying it's cost or quality. It's administration or clinical leadership. They're defining all of these ors, and they're getting themselves into a box that's not producing the kind of transformational care that we need right now in healthcare. So I'm going to ask you to think about the triple aim. When we invented this idea in 2007, we actually started going around the world and asking people, do you see the triple aim as your job? And the answer was largely no. We had some people who said, my job is to improve the experience of care. I'm working on safety or patient engagement. I'm working on efficiency, access, and flow. And there were a lot of people who associated themselves with the experience of care. We had a number of other people, many public health officials, who were saying, my job is health. And then we had the economists and the finance people who said, my job is to worry about money. But we didn't have anybody, even people you would think, who would step into the middle and say, I see all of the triple aim in 2007 as my job. So we put that little black dot in the middle and we said, we need people to integrate. We need integrators. We need people to step into a leadership position and say, we need to transform healthcare so that we're producing better care, better health at a lower cost. And that's why I'm here. I think that's why you're here, because together we can produce the triple aim. So a few years ago, when I took over IHI, we actually changed the strategic plan of IHI. In the early days of the Institute for Healthcare Improvement, and we're almost 30 years old now, our mission was to improve healthcare. And you can see here on the top of, this is our strategic plan on one page. You can see on the strategic plan that at the top on the left, a big part of our mission is still to accelerate the improvement of healthcare. But then we put a big and we said also, we're going to work with communities and others to improve health. So it's healthcare and health. And I want to give you some examples this morning of how we're doing that, how I'm seeing global contributions. Some of you will recognize some of these examples from around the world as we think about this new idea of the people who are leading healthcare organizations being the ones to take on the triple aim. So let me start on the healthcare side. About a year ago this week, we launched a new project called the IHI Leadership Alliance. And in it, we said, this is our mission: care better than we've ever seen, health better than we've ever known, cost we can all afford for every person, every time. That's the mission of the Leadership Alliance. And we got together leaders from around the US, and now we're expanding globally, so hopefully some of you can take these ideas back. And we said, there are 4 things we need to do in the Leadership Alliance. The first one is we think we need to redo the way we measure, because right now people are paralyzed by measurement. We need to strategize and create sense around measurement. What really matters? The second thing is we need to think about leadership in a different way. And this is my personal passion about leadership and joy in work, because as all of us look at our organizations, what I came to realize about a year ago is that we're managing 4 different generations. It's the first time ever that we as leaders have had to manage 4 different generations in the same workforce, and they're very different. So we really need to think about leadership in a new way. The third one is about radical redesign, and Don Berwick is leading this for us. And the fourth is a collective voice. These 40 leaders are coming together. They're organizations whose names you know, and they're coming together to say, as healthcare leaders, it's our job to transform healthcare. We shouldn't be waiting for Washington or policy. We should be taking this on because we're the ones who know the need. We're the ones that know the system. So we created this idea of radical redesign principles, and I want to share with you some examples of what we're seeing. If I could give you one homework assignment today, it would be take this one slide and stick it over your desk, and every time you feel like you're getting into the tyranny of the or, pull out the radical redesign principles, because they will help you to see the world in a different way. The first one I want to talk about is joy in work. And I believe this so passionately because I'm looking across the world at the rate of burnout or detachment, disengagement in our workforce, because they're struggling with the same pace of change that we are. And so what I'm seeing is a workforce that isn't at its best right now. This is a US problem, but I'm seeing it globally. And what I'm finding, The thing I keep saying is you can't give what you don't have. You can't give good care if you're feeling disquieted yourself. So I think a big part of our work in the next couple of years is going to be creating joy in work. I define it this way. It's gratitude for what you do. It's hope. It's a sense of abundance. And it's a deep satisfaction from serving others. If you come to IHI, and I hope you do, you're all invited. I know some of you are going to have visited and some will be coming. When you walk into the office, the first thing you see is our mission. It says, we will improve the lives of patients, the health of communities, and the joy of the healthcare workforce. And I'll tell you, the most common reaction I get when visitors come to IHI is that word joy. They don't see it in the workplace, and so they're surprised when they walk into the office and see that word, and we mean it. When you're leaving the office at the end of every day, we measure joy. So every employee, when they're walking out of the office, before they leave, they're asked to rate their day. If you had a day of joy, if you made progress, if you had a day of meaning, gratitude, abundance, and you made a difference in someone's life, you take a silver bead out of the bucket, and you put it in the tin. If you had a day of setbacks when you had made no progress, you take a brown bead out and you put it in the bucket. And every single day, we measure the ratio between blue beads and brown beads. We measure joy. And then we're constantly running improvement cycles to make IHI a joyous place to work. We're a tiny little organization. We only have 145 employees, and our mission is to improve health and care around the world. So if they're not filled with joy and abundance, we're not going to get our mission done. Brian Sexton showed me this slide, which I think is really funny because so many people relate to this. When you're at work, you're exhausted and you're falling asleep at your desk, and when you're at home in bed, you're wide awake thinking about work. You can relate. I know, we're all in this boat together. And what he's saying is that our lives are so chaotic right now that we need radical redesign on our lives so that we can produce joy in work. So I'm going to give you a test. How many in the past week of you have skipped a meal? Brian's test. Many. How many ate a poorly balanced meal? You stopped at McDonald's on the way. Yeah. Worked an entire shift without any breaks? Lots of you. Changed personal plans because of work? Vast majority. Arrived home late from work? Drank too much coffee? That would be me. Slept less than 5 hours a night? That would be me. Look at the burden. Over 40% of Americans are sleeping less than 5 hours a night. And what that does to our clinical circumstances, the rate of heart disease and the burden of illness is dramatically improved. And as Brian said, the funny thing is that this study was done by a guy named Cappuccino, so it is a little ironic. But burnout is a problem. Work in healthcare is physically demanding, it's emotionally draining, and it's intellectually challenging. And I can tell you that there are hardly any other occupations in the world that are all three. I've been doing a study about this, and what you can find is that we ask a lot of people. And then burnout affects our patients. It affects safety. Patients don't adhere to medical regimens when physicians who are burned out make these kind of recommendations, diagnoses, and prescriptions. We see less sympathy and less empathy. So it's a challenge, and we've got to work on this together if we're going to get to the triple aim. So we've got lots of improvement ideas, radical redesign of the workforce in order to help decrease burnout. But that's the first of the radical redesign principles, create joy in work. The second one I want to share is assume abundance. And again, when I'm going out and working in communities around the world, what I'm finding is that some leaders are not right now able to assume abundance. So we're using a tool called asset mapping, ABCD, asset-based community development, to go into communities. And when we talk to leaders when we first arrive, they'll often say, well, you don't understand. My population is old. The rates of drug abuse or alcoholism are high. Everybody here is overweight. The kids drop out of school. They have all of the problems and the deficits. So we walk them through using a tool that helps them to see abundance. At first, they can't get over the deficits. So we'll work with them to create a needs map. And it allows them to quantify, to see the greatest areas of challenge. And what happens is community leaders will then be able to focus in and then begin to look at the assets. And when they move to an assets-focused map, boy, all of a sudden, they find joy. They start to see that the United Way, that school teachers, and I'm going to be giving you some examples this morning, are all working on the triple aim with them. And all of a sudden, this assets-based approach allows them to assume abundance. So it does, I think, when you find that your team might be stressed or feeling like they're overwhelmed, focusing on assets is a great way, I think, to open their eyes to abundance. The third one is change the balance of power. And some of you might have heard me tell the beginning of this story before. But changing the balance of power, I think, is critical. I was in a hospital, an academic medical center in Rehov, the Rehov Hospital in Jönköping in Sweden a few years ago. And I walked into a ward, a place in the hospital, and I felt lost. I said, "What is this place?" And they said, "Oh, this is the patient self-dialysis wing." And so I said, "Wow, this is interesting." And I said that all the patients let themselves into this wing in an academic medical center with an electronic card key, and they take care of themselves. The patients actually make coffee for the nurses because they are there before any staff come into the building. And so I said, "How did this happen?" And they said, "Oh, well, we've been working with IHI for years. We're very innovative." And I said, "No, I know of no CEO in the world who would say, let me build a wing of an academic medical center and have all the patients come in and take care of themselves." And I know patients do their own hemodialysis, peritoneal dialysis, but I've never seen a CEO build a wing in order to have the patients take care of themselves. So I said, "How did it really happen?" And then I met Christian Farman. He was a young guy. He was a mechanic at Saab Avionics and came down with glomerulonephritis and ended up on dialysis. Now, he was a mechanic. So after a couple of weeks of having his dialysis done to him in the unit with the very sick people and the younger people, he said to his nurse, "I want to do that myself." So she taught him how to do it. And then they taught the 73-year-old lady in the next bed how to do it. And then pretty soon, they had aimed to have 75%. Last time I checked, 70% of the patients in this academic medical center were in the self-dialysis wing doing their own care. So I met with Christian. I've spent many, many days with Christian now. And I said to him, "What prompted you to ask to do your own treatment?" And he said, "I want to live a good life." He taught me about post-dialysis syndrome. He said when you're chronically underdialyzed, you have to go home and go to bed for the rest of the day. He said, "I had a feeling that if I took control of my own life, if I changed the balance of power, that I could produce a better life." And I said to him, "Christian, what matters to you?" And he said, "I want to work. I want to work." And that was the most important thing to him. The big surprise was I said, "Christian, tell me about safety." And I was expecting him to say, "Well, I have a cell phone and I can call for help if I need it." And he said, "Well, of course the care is safer in my hands." He said, "I do it the same way every day. You have a different person come in and you all do it in a different way. Plus, it's my bacteria, not yours. I'm not going to infect myself." He said, "Of course the care is safer in my hands." So I talked to Annette, the nurse leader, and I said to her, "Where did you come up with the idea that you should go to the CEO and not say, we are taking care of some patients and some are taking care of themselves, but build me a new building?" And she said, "Well, I started to see that the patients who were taking care of themselves didn't need us so much. But I knew I wasn't going to get economies of scale if we had all the patients in the same wing. So I knew if I could get the majority of patients caring for themselves and I could segregate them, we could decrease the cost of care in that unit substantially, and that's what she did. So PDSA, Plan, Do, Study, Act, teaching Christian, teaching the 73-year-old lady, getting more and more patients, then Annette going to the CEO, and then building the building. So I said to Annette, what's your job if you're a head nurse and you don't do anything with patients? And she said, my job is I look out and I've asked all of these people in my unit, what matters to you? And she said they all said the same thing Christian said, I want to work. And so she said, I looked out and I said, they're not working. So now when Annette admits a patient into the self-dialysis unit, the first thing she does is she sits with them and they fill out their CV. They update their resume. Now, your second homework assignment is to go home and visit your own dialysis unit. Ask the head nurse, how many people here are working? And you'll be surprised that I bet you that they don't know. Because that's not what drives the nurses. It's about giving care. But for Annette, it's empowering, changing the balance of power so that the patients can work. So I said to Christian, so did you go back to Saab? Did you go back to the being a mechanic? And he said no. And I was thinking, oh, that's a failure, you know? And he said, no, I'm an RN. He said, I decided to go to nursing school. So I'm now the head nurse on the ENT unit in the academic medical center. So the next year I went back and I said to Christian, so now you're a nurse. What matters to you now? And he said, I want to get married. And then I had the great joy of getting invited to his wedding. And meanwhile, he kept transforming the unit. This is the dialysis unit at Rehov. Go back and look at your own. Every patient exercises. Some of them are exercising while they're dialyzing, but every one of them is fit. This is the triple aim. They're healthy, they're getting great care, and they're doing it at half the cost. This is the triple aim, but it's transformational. Now, I've been trying to get this to spread around the world, and it's slow to spread because I think people see all the barriers. They see all the needs and not the assets. But I challenge you to go back and think about this because this is a radical redesign concept that will help us to move to the triple aim. Great results, great results. And so last year when I was with Christian, I said to him, I couldn't make your wedding. What matters to you now? And Christian said, I want to have a baby, and here's Wilmer. And it's so exciting to see somebody who began his healthcare journey by seeing himself as a chronic patient, completely dependent, to have Wilmer in his life now is breathtaking for me. But it's going to take radical redesign. It's going to take courage on your part. Shift the balance of power. Another one is connecting to each other. This is a map made by one of our faculty, Kristen Lind. She's got a severely disabled child. And we asked her, draw what it looks like for you as a mother of a severely disabled child. And look at how complicated it is. Gabe is in the middle, and then the family, and then there's all the health care. And what we found was when we started to show this to doctors and nurses is they could find their own little bubble, but they had no idea of the complexity of what care looked like. So I think we need to figure out how to connect people, how to see the whole. I was in Hong Kong last week and in Singapore a few weeks before, and I met a physician who said the sicker the patient, the fewer professionals they'll need to interact with. Will take on the burden of coordination. And I loved that. The sicker the patient, the fewer interactions you have to have. And then recently out at Stanford, talking to a physician who said, we'll take on the complexity of care. That's a design challenge that I would say is so important for us, so important for Kristen and her son Gabe. Because right now, she's navigating that whole system by herself. And to have healthcare leaders stand up and say, the sicker you are, the more I'll take the burden of complexity is breathtaking for me. That's where we need to go for the triple aim. I think we need to think about collaboration and coordination in a different way. 2 years ago, I was in London at a meeting, and it was just like this. People in the audience were talking about beginning to transform change. And there was a staff nurse out in the audience whose name is Jen Rogers. And I said, The biggest thing I want you to take home is this. We need to stop only asking patients, what's the matter with you? And we need to ask them also, what matters to you? So this staff nurse went back to her hospital. She was a head nurse in one unit of a pediatric academic medical center in Glasgow. And what she started to do was the next day, she gave every patient who was admitted a piece of construction paper and a little art kit, and she said, put your name and your age, and draw on this piece of paper what matters to you. This is an example. This is, Kendra's What Matters to Me. Kendra is 7 years old. Kendra is severely autistic and has never spoken in her life. So she and her father, on admission, sat down and they drew out this piece of paper to put on her door. She wrote, I don't like medication by my mouth, so I will struggle. It's a 3-person job. The way that Kendra says hello, because she can't speak, is she reaches up and she pulls your hair. She said, I'm very fast and I put things in my mouth and I will run for it. I can make a run for it, ha ha ha. She said, I love cuddles to reassure me. And she said, I can dress myself with some help and I can high five. Now, the night that Kendra was admitted, her father, who's her only caregiver, had a cardiac event and he was transferred by ambulance to the other adult hospital in Glasgow. And Kendra was all by herself in the hospital. And the doctors and the nurses said, imagine if we didn't have this map on the door. We would have walked in, she would have pulled our hair, she would have kicked and fought and struggled when we tried to give her a med. We would have likely ended up restraining her, and it would have been in completely different circumstance. But they said, because this picture was on the door, we now knew how to take care of Kendra. So now every child in this hospital, this one nurse sitting in an audience just like you, heard this one phrase, took it back, and transformed the hospital. Her best friend is a geriatrician, a geriatric nurse in the adult hospital. So she started doing it. And I will tell you, every single week now, I get stories like this from around the world. I get stories from people in Singapore, from people in Brazil. I got a wonderful story from a nurse in Brazil who said she had no voice except through, she felt like she wasn't being heard when she was speaking. But when she put this up on her door, it changed her interactions. I got a wonderful story from an elderly lady in Scotland who said that she was admitted to the hospital because she had fallen, and she was depressed because of her deteriorating condition. She was 78 years old. And the physicians were in the hallway, and they were talking about antidepressant medication and putting her in a nursing home. And then one of the nurses walked in and said, Bernadette, what matters to you? And they made a little map and they put it on the door. And what she said is that she had lived in Brazil for 42 years. She spoke fluent Portuguese. She had been a member of the Women's Air Force in World War II, and she had been knighted by the Queen. And I'll tell you, when people walked in to talk to her after that, totally different conversation. All of a sudden, she was a person, and it meant something entirely different to have an interaction. She's home now, taking care of herself and doing very well, when she was headed for a nursing home without this simple piece of paper on her door. Here's another story, a physician who I think in a very busy day will customize the care to the individual. He's not thinking only about care pathways and guidelines. He's thinking in a very simple way, not only about how he takes care of patients, but also how he can be a great teacher to residents at this hospital. Mark, could you roll the video?
Doctors and hospitals really aren't what we call conversation ready, because we ourselves have so medicalized everything that I'm seeing for this patient. What's the dose of this medicine? What's the chemotherapy or not? With this test or not? That we ourselves don't actually often have the experience, the practice, the support that we need to sit down with a patient as a human being, understand what's important to them as a human being, and make sure that that's always at the center of every medical plan. was asked to see Thelma Patello. All that I knew was she was a 92-year-old woman who had severe vascular circulation problems in her leg, causing her lots of problems, for which there wasn't going to be any effective treatment that they could offer except amputation, which she just refused. She wasn't going to have that done. And so they said she didn't have that long to live, and so they wanted me to come by and maybe talk to her about hospice kind of options.
What I remember, I guess, most strikingly was that Dr. Farrow asked her, what would be a good day for you?
And so I sat down on the bed. I said, getting to know you some as a person will help me figure out how I can best help you.
And it's such a simple question. What would be a good day for you? What do you like to do? These things that I don't feel like I have time, honestly, on a daily basis when I'm seeing patients, when I'm on call, to ask these little things.
In whatever time there is ahead for you, how can we make that as good as it possibly can be for you? Singing is what made it a good day.
But it didn't take that long to find out that this is what was important to her.
I said, when was the last time that you sang? And she just sort of said, I haven't sung in a long time. I don't sing anymore. I said, why not? And she kind of looked at me and I said, how about singing me a song?
I see trees of green, red roses too. I see them bloom for me and for you. And I say to myself, what do you say, darling? What a wonderful world. Somebody, where's the drummer?
I see skies of blue.
I see skies of blue.
Clouds of white.
Clouds of white.
The bright, blessed,
The bright, blessed sun. And the dark, sacred night. And I think to myself, what a wonderful world. And I think to myself, what a wonderful world. Pop, 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 pop. Oh, yeah.
And it made such a huge difference in her day.
The music was right there as vividly as it had ever been. And every time her voice started to sing, you could just see her eyes getting younger, her face getting younger, and a kind of human joy returning.
So when you go back to work, do your staff have enough joy to walk into a room and say what makes a good day for you? What I see is that so many clinicians are standing outside a door and they're thinking, I have a 92-year-old lady with leg ulcers, instead of, this is the coolest lady on earth, because I think Thelma Patello, Dolly Baker, a jazz singer around the world, had so much to teach us. And I think that's the kind of assets that we need to build. So think about that. And now I want to take you to Singapore. I was there, as I said, a few weeks ago, and looking at a unit with a lot of patients who had dementia and thinking, how did they take care of patients like Dolly? And the first thing they did was bring me over to show me with such great pride that this unit, this dementia unit, had 861 days with no restraints on the unit. 861 days. So I said, well, how did you do that? And they said, well, we really customized the care to the individual. One example is, do you see where I'm standing? Those are the doors to the unit. They made them look like bookcases. And because they found that when it looked like doors, the patients were always jumping up and going to run out, and then they had to use restraints. So what they did was they said, where are you going? And then what they did, they made the doors look like bookcases, gave the patients a book on their bedside table. All of a sudden, nobody's running through the doors anymore. I think it's a wonderful example of really digging deeply rather than responding quickly and really asking what matters to you. Another one of the really key design principles, I think, is move knowledge, not people. We heard that this morning in Dr. Etienne's talk, that we need to start thinking in a totally different way. And this is a project that was led by Dr. Sanjeev Arora in New Mexico. He was the hepatitis C expert for the state of New Mexico. And just like Dr. Etienne was saying, the long lines to get into his practice for getting medication, diagnosis, were mind-boggling to him. He didn't have joy in work because his waiting list was endless. The patients certainly weren't happy because they were waiting months to get in to see him. The staff were always running, always behind. And then the patients would often have to drive 200 or 300 miles to get their care. So he changed to say he was going to move knowledge, not people. This is Sanjeev Arora, the guy with the tie sitting under the E in ECHO. And this is how he takes care of patients now. Every Monday morning, he goes into a room with a very inexpensive little video camera. And all the primary care clinics, first in the state of New Mexico, then around the country, anybody who's struggling to take care of patients with hepatitis C, they call in. He's not doing telemedicine, he's doing teleteaching. So he's using case studies to teach primary care physicians how to take best care of people with hepatitis C. So he'll say, this morning we're going to talk about a 28-year-old patient. He's newly diagnosed. He's got these other clinical circumstances. He's got this kind of access to health care. And then together, they create a best pathway for this patient. So he's teaching in a 2-hour block physicians, not only from the state, from now across the country, and Sanjeev and I are partnering on a project to expand this even broader. And what you're seeing is that the treatment outcomes are better when he's doing Project ECHO than when he's taking care of patients himself. So this one doctor who had no joy, who was constantly behind, said, I think I need to move my knowledge and not the people, and the results are amazing. So this is what the schedule looks like for that room nowadays. Sanjeev is in there Monday mornings, but then all the other things that are daunting primary care practices, like dementia care, complex pregnancy, rheumatology, looking at chronic pain, all of those, a different specialist will come in, and anybody who wants to can tie into this free teleconsultation. And what we're finding now is that not only is Sanjeev in a very good place about the impact he's having, but the primary care doctors love it because they're not sending their people away to get a little bit of their diagnostic and therapeutic work done and then trying to integrate them back in. So it's a different principle when you start to think, I'm not going to require every patient to move to me. I'm actually going to move my knowledge, not the people. A different principle is make it easy. And this is one I learned from the Netherlands. I spent time recently with Joost de Blok, who was a registered nurse. He worked for many years doing community care nursing. And some years ago, the healthcare system changed, and they started to think that they were becoming more efficient. So what they said to the community nurses is, we want everybody in the community to work up to the level of your license. You've heard that term. So we want RNs to do things that RNs can do, and we want home health aides to do things home health aides can do. So what they started to do, in thinking that they were improving efficiency and improving finances, was they started fragmenting care. They took all the joy out of work. So Joost decided to leave his job and to start up a different way to produce home care nursing. He said, I'm going to get a team of RNs, and we will sit in, we will take care of a neighborhood. He founded an organization called Berzog, which means neighborhood care, and he created teams, first one team and then two. What happened is, when he found a team of 10 or 12 RNs, and they took a neighborhood, they would meet every morning, and I went and sat in with Joost de Blok and some of the Berzog teams. So the nurses get together in the morning, they have coffee, they know each other and their skills very well. So if I went to visit a patient who was having problems with his colostomy, and the nurses said, well, you're the expert on this, so you go today. But between that team, they knew every patient, they knew every family member, they knew not only the clinical needs, but the social needs, and they were able to put together an amazing plan of care. They also come together at lunch and talk about what their days are like. They cover for each other. It's an incredible thing now to see better outcomes, more joy in work, at a lower cost, the average cost of 40% lower. So the country could save about 2 billion euros if they can get the last bit of people to start to work in Berzog. The model has flipped from fragmenting care and segmenting care to consolidating care and empowering people. And I was going to put a picture on of me trying to ride a bike in the red light district in Amsterdam, which did not go well. I can't ride bikes anyway. I'm 5'3". Everybody in the Netherlands is 6'3", I think. And so I'm on this big, giant, heavy bike trying to navigate over the cobblestones. And let's just say I was glad to be with a group of nurses who were really excellent at the kind of care that I needed. But this is spreading worldwide now, because I think what we're seeing is, rather than managing people, when you empower people, when you bring them together, that they can produce incredible clinical care at a much lower cost. So those are some examples of radical redesign principles on the healthcare side. I want to spend my last few minutes with you thinking about the health side and thinking about how we as healthcare leaders, with an assumption of abundance, with a different view of what we're doing, can begin to move upstream and produce health as well and reliably as we produce health care. So a year ago this week, we launched the Leadership Alliance, and a year ago this week, we launched 100 Million Healthier Lives. Again, a campaign that we're beginning in the United States, but hoping to spread globally, so feel free to take this back. But what we're saying here is that we can't produce 100 million healthier lives by producing health care the way we are. We need to bring a coalition together, and just celebrated last week with people from all over the country coming together, school teachers and public health people, police departments, people who work in Veterans Affairs. Everybody, these communities that are coming together, are looking deeply with the asset maps into their communities, and they're picking a population that they want to focus on. One community is working on getting every veteran into permanent housing. Another community is working on keeping every child vital up to age 5, because then you've bought 75 years of future health. Another community is working on getting 15,000 people out of poverty, because that's the most direct line for these people to get to better health. And another community is working on keeping the elderly vital at home. So each community dug in, looked at their needs map, looked at their assets map, and the energy in this group is breathtaking. It's, as I often say, we've got to broaden the view. We've got to look beyond the healthcare system. We talked this morning about the World Health Organization's definition of the social determinants of health, the conditions in which people are born, grow, live, work, and age. And then they say, ... including the healthcare system. And I'll often show this map to healthcare leaders who think that the hospital or the clinics are the most direct route to health. And I'll say to the healthcare leaders, can you find healthcare's contribution to health? And I'll have to put a little red circle because it's so small. So we really need to understand the assets everywhere if we're going to produce better health for the Triple Aim. I'll share with you a story from Scotland. In our 100 million, we began by teaching people in Scotland. We set out a goal about 5 years ago to make Scotland the healthiest country in the world in which to grow up. That is, until you all go back and decide you want to be the healthiest country in the world in which to grow up. A challenge for you. But we started working in Scotland 5 years ago on creating health for kids. And one of the people in the audience, just like you today, was a school teacher. She teaches in a primary school in a little town called Stirling in Scotland. And she learned quality improvement methods, PDSA, and she got it into her soul. At her school, every week, this guy comes. He's an earl. He's a very wealthy guy. He owns a castle. He's, one of the champions of the community. But every week, he comes down to the primary school, and he teaches the kids poetry and music. And one day, he was sitting there teaching the kids, and he looked up at Elaine, the school teacher, and he said, "Elaine, these kids are fat." And her reaction was, "Well, that's not my problem. I'm a school teacher." And he said, "It is your problem. These kids are fat." And so Elaine, being an improvement person now, said, "I wonder if I can run a test, a PDSA." So she said, "Okay, I think I'll get a couple of the kids and we'll go out and we'll run around at the recess." And what happened was I had to get Derek Feely to translate for me. She said they couldn't run the length of themselves, which means they couldn't go far at all. They couldn't run the length of themselves. She said they ran at a scout's pace, which meant they were really slow. So she said, "I need to use quality improvement." So she used improvement science. She got a couple of kids, and she figured out that if the kids ran around the school 5 times, then that was a mile. So she got a couple of kids and then more and more, and she said, "Every day we're going to run the daily mile." And here are her PDSA cycles. She started with a few kids, then she got her whole classroom, then she started with other schools, other grades. And the way it works is this: every kid goes out each day. They don't change their clothes because when they did a PDSA on that, and they were taking forever to change their clothes so they wouldn't have to be in the classroom. So they run in their clothes. It's 15 minutes maximum. The teachers can decide at any point during the day when to do it. No need to change, no training for the teachers, and it was free. So think about this. The kids were fat. They couldn't run the length of themselves. She implements this PDSA cycle, and all of a sudden, every kid knows about the daily mile. Every child is measuring themselves. So this little girl has 5 blocks, and she puts the blocks on top of each other so that she can keep a track that she's doing the daily mile. The impact is amazing. There are 420 kids in that school, and there's not one overweight child. Not one. Every single kid is fit. Every single kid can run the daily mile. Free, no training required, except improvement science. The parents say their kids are different. The parents say that their kids are sleeping better, they're eating better, and then, as always happens, the little kids are having an influence on the parents. So now all the parents are having to run the daily mile, and the parents are having running groups, and the kids are, constantly intervening with the parents and trying to improve health. The teachers say that the kids have much better attention span and that their relationships are better. They said kids that would never walk up to the front of the classroom and approach me with a problem will run alongside me. And all of a sudden, the kids' grades and attention are improving. So the daily mile has produced health in a way that I don't think we in healthcare could have without this interaction, without looking beyond the bounds of healthcare. So you all came to this meeting because you have IQ. You have high intelligence. That's why you're in healthcare. And you all came because you have EQ. You care about people. That's why you went into caring, emotional quotient. I want to push you on CQ. You've got all these days together. And what I'm finding in my research is that CQ is actually more highly related to success than IQ or EQ. So ask questions. Go and talk to people. Find out. Go and look. Do the site visits. Find out anything you can find, because that CQ is, I think, what's going to be the biggest difference in our ability to transform healthcare. With your team, I would say innovation. All of these examples that I'm giving you this morning came from people working in healthcare, but they learned how to innovate. At IHI, every 90 days, We run 5 to 7 innovation cycles. If you have a problem that you haven't been able to solve, send me an email. We'll put it into the pipeline. We've got to come up with new ways to innovate. The second is spread. We're so tolerant of variation in our healthcare systems. We'll see one unit that's eradicated infections and another one that regularly infects. We'll see waits and delays in one clinic where another has been able to eliminate them. We as leaders have got to get intolerant to that variation and spread best practices reliably. Spread is its own methodology. That's a leadership thing that you've got to learn, I think. The next one is exnovate. And sometimes people ask me, what is exnovation? Exnovation is getting rid of all the junk in your life so that you have energy to innovate. Because what you find when you go back is you're going to find those people who are focusing in, who are putting their heads down on the desk. And if you as a leader don't exnovate, if you don't get rid of all the stuff, and I've had people from other industries regularly come into healthcare, and they can't believe the way we work. They can't believe that we have electronic records and paper records, that we have stuff stored away in a cabinet in case something bad happens, that we still have meetings where nothing's happened in a year. They can't believe that we don't exnovate. So I'm going to push you hard on exnovation. When I was CEO, I got my team together, my CEO at a hospital. I got my senior team together, and I said, why can you not innovate? Why can you not spread? And they said, oh, we're too busy. So I said, well, what are you doing? And they said, we're really busy. So I said, okay, next week, bring your schedules, your calendars for the month. And we looked through, and indeed, they were meeting all the time. So I gave them a class on how to run a great meeting, and then I said the next week, from today forward, every meeting in the hospital, except for the board meeting, is cut in half. You can meet half as often or half as long. And nobody missed a beat. For many leaders, that freed up 20 hours on their calendar. All of a sudden, they felt free to energize and to innovate when they would never have done that on their own. We looked at reports. They said, we're consumed by making reports. I said, okay, bring all the reports that you or your department do to the meeting next week. And I said, okay, write on the report the name of the person who's the customer to the report. We had customers who had been dead for decades, and we were still producing the report. I said, go talk to the customer. What do you do with this report? Oh, I don't do anything with it. I throw it away. Or I only need that one number. I just stick it on a shelf. So when you surface the idea of exnovation, you can free up so much energy, eliminate so much angst. And then finally, I would say we need to undiffuse. There's so many old practices that we're still doing, and we need as leaders to get in when the evidence changes and reliably go through a process of undiffusion. So think about exnovation and undiffusion if you don't have them regularly as a part of your life, because I think that it's the only way we're going to free up the kind of energy that we're all going to need in order to totally transform the system. So remember, use your CQ and reach out to learn. Use your IQ and your EQ to teach. But it's all about all teach, all learn. Thank you so much.
Wow. Didn't I tell you you were going to love her presentation? So let's give Maureen another round of applause. Thank you, Maureen. What I love about what you have to say is you've not only given us a lot to think about, but you've given us a lot of hope for the future. So I have another important task to do before you all rush off to lunch, and that is to present a call to all leaders to professionalize healthcare management. I think we all know how important leadership is, and in fact, I believe that leadership does matter. Still, many countries lack a formal recognition for the profession of healthcare management, and many managers lack the professional training and fundamental competencies. 3 years ago, the Global Consortium of Healthcare Management Professionalization began working to identify the developmental needs of individuals running healthcare organizations, regardless of organizational type and et cetera. Through their work, the consortium recognized the need for a contemporary model that starts with the needs of society and, of course, the needs of the patient. I'd like to welcome the members of the consortium of healthcare management to the stage right now. You can see their names listed, but please join me on stage so we have an opportunity to recognize you as well. Let me just tell you a little bit more about these great people. This consortium represents from over 17 organizations, but the community is much larger than that. There were over 100 healthcare professionals and academics that have contributed to the written open review process. You have this publication in your portfolios bags for the meeting itself. And they offered their input during that open review process and in several occasions that we had to make presentations all over the world. So again, it is my very great pleasure to thank the consortium members for all their hard work these past 3 years and in moving this important work forward. Thank you again to all of you. Feel free. And now, I'd like to introduce Dr. Ronaldo Holder, Regional Advisor, Hospital and Integrated Healthcare Delivery of the Pan American Health Organization, part of the World Health Organization, to present the specific call to action for the professionalization of healthcare management. Ronaldo.
Thank you, Deborah. Leadership matters. The evidence is convincing that the efficient and effective use of resources and the quality of healthcare services provided is improved by enhancing the management capacity of individual leaders and teams. As the healthcare portion of nations' GDP continue to increase, the pressure for enhanced management capacity will continue to grow. Yet, healthcare organizations face two key barriers to realizing the benefits of professional management. The first is the lack of adequate management preparation in the training of many healthcare leaders. The second is the fact that the role of healthcare manager is not recognized as a profession in all countries. The consortium is calling for your commitment in the professionalization of healthcare management through 4 main areas. 1, the adoption of the leadership competencies for healthcare services managers to train and align healthcare management development at all levels of the health system. 2, formal recognition at the national level of healthcare management as a profession that requires training and the development of specific competencies. 3, implementation of merit-based career advancement along with a career path of healthcare managers. And 4, recognition of healthcare managers, professional associations as key stakeholders for policy dialogue related to leadership and management and for the advancement of the profession. I'd like to finish with an invitation to join the consortium in this call to action for the professionalization of healthcare management. To get involved, hear about case studies, and learn more, please join us during our panel discussion on Thursday from 10:30 to 12 p.m. in Columbus Hall, located at the gold level. Please note that lunch will now be served in the exhibit hall 1 level below this room. Thank you very much, and enjoy the rest of the day and today's conference.